In this video, we will discuss the following abnormal patterns: periodic lateralized epileptiform discharges, periodic sharp wave complexes, periodic generalized complexes, triphasic waves, burst suppression pattern, and coma patterns. Let us start with periodic lateralized epileptiform discharges, or PLEDs. As suggested by their name, they are periodic, lateralized, and epileptiform, that is, more than 75% of patients showing this pattern are likely to have seizures. They consist of di- or multiphasic spike or sharp wave complexes, and may include a slow wave. They stand out from the background activity due to their higher amplitudes, which are in the range of 100 to 300 microvolts. Their total duration is usually 100 to 300 milliseconds, and they recur every 2 to 3 seconds. They are seen in acute or subacute cerebral lesions like viral encephalitis, including herpes simplex encephalitis, brain abscesses, stroke, rapidly growing brain tumors like glioblastoma multiforme, etc. Periodic sharp wave complexes are most often seen in CJD as bi- or triphasic waveforms, with a frequency of about 1 Hz, and duration up to half a second. The background is usually highly abnormal, and consists of generalized, asynchronous slow waves, of low amplitude. EEG is considered as the most reliable, non-invasive, diagnostic tests for CJD, as a repeatedly normal EEG is distinctly uncommon. Periodic generalized complexes are often seen in SSPE as high-voltage complexes containing 2 to 4 high-amplitude delta waves. Their amplitude ranges from 300 to 1500 microvolt. They recur every 3 to 15 seconds, and these complexes last up to 3 seconds. These complexes are time-locked, with the clinical myoclonic jerks. The interval between complexes shortens with disease progression, and is ultimately replaced by disorganized slow rhythm. Triphasic waves consist of waveforms with 3 phases, each succeeding phase with longer duration than the one before. The second phase is positive in polarity, and usually has the greatest amplitude of the 3 phases. They are diffuse, frontally predominant waves, with amplitude usually exceeding 70 microvolts. Triphasic waves are frequently encountered in metabolic encephalopathies, and hepatic encephalopathy is an important consideration. Other causes include Hashimoto's encephalopathy and lithium toxicity. Burst suppression pattern shows alternating periods of bursts and suppression, where bursts consist of regular or irregular, slow waves of high amplitude, with or without faster components, and suppression consists of periods of low amplitude, or flat EEG. Bursts are generalized, usually synchronous, and may last from 1 to 3 seconds. This pattern occurs in a variety of severe disorders of cerebral structure or function, like postanoxic encephalopathy, head injury, stroke, etc. Drug-induced sedation and hypothermia are 2 potentially reversible causes of burst suppression pattern. Alpha coma is defined as the appearance of EEG activity in the alpha frequency range in an unconscious patient. This pattern is mostly anterior predominant, symmetrical, and highly persistent. It does not vary with stimulation, and is believed to result from midbrain involvement. The prognosis of alpha coma is extremely poor. All patients usually either die or survive in a chronic vegetative state. Beta coma is defined as the appearance of EEG activity in the beta frequency range in an unconscious patient. This pattern is generalized and symmetrical. It usually occurs in coma, caused by or complicated by barbiturate or benzodiazepine intoxication. As a result, it is usually associated with a favorable outcome. Spindle coma pattern consists of recognizable sleep spindles occurring in comatose patients. It may be seen in severe conditions like postanoxic encephalopathy, head injury, stroke, drug toxicity, etc. Some of these patients are associated with preserved brainstem reflexes, and therefore may have a better prognosis. Overall, the spindle coma pattern is considered unrelated to prognosis.